Hello, and welcome back to the ACRO Podcast CURiE Conversations. I'm Dr. Veronia Fahmy, a member of ACRO's CURiE team and a radiation oncology resident, second year at Loyola University Medical Center in Chicago, Illinois. I'll be your host for today's episode. Today, we're discussing a recently published article on wound dressing for radiation dermatitis in head and neck cancer patients, titled A Silicone-Based Film-Forming Gel Wound Dressing for Radiation Dermatitis in Head and Neck Cancer Patients, a retrospective cohort analysis using clinical informatics. I'm joined today by one of the authors and the PI of the project, Dr. Ricky Savjani from UCLA, who's going to be talking a little bit about the project and how it's going to impact our future practice in radiation oncology. Dr. Savjani, thanks for joining us today. Could you please start by introducing yourself and telling us a little bit about your role in clinical focus?
Of course, good to meet you, Dr. Fahmy, and thanks for having me on the podcast. My name is Dr. Ricky Savjani. I am a radiation oncologist at UCLA, and I got into radiation oncology through the path of imaging. My father was an MRI technologist. My brother is an interventional radiologist, and several cousins who are in the field of radiology. So I also thought that I was going to go down the path of radiology until the very end of my third year of medical school, when a really good radiology mentor of mine, Dr. Steve Fung at Houston Methodist, said, "Hey, you might be interested in the field of radiation oncology. It's a bit different. You do see patients and follow them longitudinally after you treat them, and it has some interesting avenues for research while still having imaging at its backbone." So he sent me down to the basement in Houston Methodist and got to hang out with the radiation oncology team there. So I changed all of my away rotations from radiology to radiation oncology. And I think there was no turning back for me after that point. So that's how I got into radiation oncology. Um, and then this project in particular was sprung about because there was an Australian study in 2019 that was published in the Green Journal that did a randomized trial comparing sorbolene, which is Aquaphor, compared to StrataXRT, which was this new compound that is this Mepilex film, this film-based silicon gel form that's used as a radiation protection or barrier for head and neck cancer patients. And we saw that data. Dr. Chin, Robert Chin at UCLA was my mentor. I was in residency at UCLA at the time, and we adopted that in about 2020, where we switched patients from getting Aquaphor or Calendula standard moisturizers to getting StrataXRT, and we did that for a number of years. And then we had some collaborations with StrataXRT, Strat Pharma, the head pharmacy, and they said, what's your experience been like? And at this time, I was starting to get more into clinical informatics, and rather than have a medical student or me as a resident go through all the charts of patients and look at the CTCAE scores, I realized we could do that pretty automated because we had access to the notes, and we could extract out pieces of the notes that would say the CAE scores and look at patients who had StrataXRT. So that's what spearheaded the project.
That's wonderful. And yeah, I do think that the aspect of the clinical informatics use is very interesting. As you had mentioned, it could be very daunting to go through, tons of charts. So do you think this approach could make retrospective toxicity studies easier for other institutions to perform?
I do. So the way that it works at UCLA and many institutions is they will provide you either a sandbox environment in which you can take extracted notes that either you yourself can write the SQL queries for to extract the data in certain institutions, or they'll have informatics software engineers who will pull the data out for you, put it in a sandbox environment, so that you can have access to not only the notes, but the imaging records, the pathology reports, the radiology reads and impressions, and medications and other things. So my lab over the years has started to use that much more heavily, so that we can do, this particular study had 171 patients in each arm, both the control arm and the StrataXRT arm. But some studies that we were interested in now are doing, thousands of patients. There is something else that's worth noting when people want to do larger data set studies that I think the listeners of this podcast may be of interest. So I think people know about these national databases like NCDB and SEER databases. Sometimes the data there are a little limited or may not actually have like the full clinical notes. If you work with your institutions, you can likely get access to those notes. And in fact, there was an initiative that was set forth by Atul Abut at UCSF, who was the chief information officer. And what he did at was, thought that this was such an important initiative that he built something called the UC Health Data Warehouse. So it combines six different University of California hospitals. That's UCLA, UCSD, UCSF, um, Davis, Irvine, and Santa Barbara. Um, or Riverside. And so these six institutions all have a common framework, a Databricks environment in which you can access data. So we're doing projects there as well. So I do think that having access to structured data can help you. And I think the thing that probably people are moving towards in the informatics space is not only getting structured data out, but could you get unstructured data out using LLMs. And there's offerings that UCLA has and other institutions have, and it's of growing interest as well.
Awesome. Thanks so much for sharing all of that. So do you mind telling us a little bit about the main findings from the analysis?
Of course, yeah. So the main the primary outcome of the retrospective study was to see if what the incidences of grade 2 radiation dermatitis was for patients undergoing head and neck cancers. So we did, in order to get a good control, because this was not a prospective randomized trial, employed a technique called propensity score matching. So we said, all the patients who have StrataXRT, who've had enough OTV visits, on treatment visits, who've had, greater than 20 fractions of treatment, those are about 171 patients since 2020 to about 2023 when we looked at this. And we compared that to, what would our control group be? So there's many ways one can do propensity score matching on many different variables. But one of the most important variables that I thought would be is looking at the skin dose. And we looked at, and we wanted that to be matched because that was one of the key determining factors that we thought would contribute to radiation dermatitis was how much radiation did the skin actually get on planning,
Mhm.
and we looked at that. So we did three metrics of propensity score matching. So we wanted patients in each arm, the StrataXRT arm versus the conventional moisturizer arm, to have a similar level of one of the key important factors was the S40, which is something we don't really think a lot about, but it's the surface area getting 40 gray or higher of radiation. And that was one of the key things. But we also looked at the mean skin dose and the max skin dose, and we tried propensity score matching. And we found that that actually worked because we have a much greater number of control patients because we had been treating patients without StrataXRT for much longer. We did try not to go too far back in time because if you went back, our data sets only digitized through 2013. And even if you went back to 2013, some of your techniques might be a little bit different. Um, and so we tried to go back to about 2016 and after to get our propensity score matching. One of the criticisms that we had or not a critiques that we had was that even in that part, it's that the control group was treated earlier. And that's one of the key reasons why I thought that we should have the skin dose propensity score matched even over other variables. Um, and so that was the cohort that we used to define.
Gotcha. And can you tell us a little bit about the actual findings of the study?
Yeah. So then we did a Kaplan-Meier curve, or we looked at what was the time to event of grade 2 or higher radiation dermatitis. The reason we chose grade 2 was because at grade 2 there's a significant effect where patients will have skin peeling or moist desquamation. And when that happens, you have to do an antibiotic burn cream like Silvadene or Mepilex paddings. And it could also potentially cause interruptions or delay in radiation treatment. We really, and the package time in head and neck radiation is quite important, where you want to get patients through as quickly as possible with as few as interruptions as possible. So we chose that as the primary outcome. When you look at the Kaplan-Meier curves, there's space between where the grade 2 radiation dermatitis is delayed. And that space is there throughout the 7 weeks course of patients getting radiation. So we're only looking at the CTCAE scores of radiation dermatitis at the weekly checkpoints. And at the end of this, StrataXRT didn't, at 7 weeks, it didn't cause an overall drastic reduction in the amount of grade 2 radiation dermatitis, but it delayed the onset. And when you look at this, that was, one of the main findings. We also did a Cox proportional hazard model where we said, and when we account for other factors like age, whether the patient's got chemotherapy or surgery, you can still see that StrataXRT, the usage of that, is one of the only variables in our analysis in this cohort of 171 patients in each arm that had a significant reduction in grade 2 radiation dermatitis. And then that was a key finding. And then we also looked at, what was the number needed to treat? How many patients do you need to treat such that you can spare one grade 2 radiation dermatitis? So we did those analysis and found that if you treated 7 patients with StrataXRT compared to moisturizer, you would spare one grade 2 radiation dermatitis. And we thought that that was a pretty significant finding because we could do that. And then the other thing was that when we looked at what was the percent reduction in grade 2 radiation dermatitis, it was about 14.5% or 15%. And so we can spare that, and that's where the number needed to treat the about 7 patients comes into play.
I was going to ask you a
No problem.
follow-up question. I was
Go
going to
ahead,
ask you,
please.
if you truly saw a change in practice in your own clinical practice, and if there were any limitations to applying that to the practice, and if there were any future directions.
Yeah, great question, Dr. Fahmy. There are some key limitations here. So one that, there was a phase 3 randomized trial in Australia that found very similar effect sizes and overall very similar results. So this is kind of a key thing that I liked about this, is that this was real world, right? We're not applying the moisturizer to patients. We're just telling them what to do and counting on them to do it at home. And what patients generally told us, qualitatively, was that they actually, quite liked the StrataXRT, the consistency, the application of it, the ease of it. So that part was quite nice. But in our analysis, it is retrospective. So, we're only relying on chart review and patients, doing this on their own. But what is supportive is that even in the real world application of the data, we are, or of the application of StrataXRT, we're seeing the same results. We did change our practice in 2020, where mostly all of our patients were getting StrataXRT. One key limitation and one of the reasons that motivated the study is that there is a barrier, not that also have impacted us, but some other clinics as well, which is that patients, sometimes insurance does not always cover StrataXRT. So you do have to write it as a prescription. And if it isn't covered, then unfortunately patients can't receive it. And so this is one of the reasons Strat Pharma wanted us to involve us to publish on a US-based study where we can maybe get some more support. There's a clear benefit of it. It supports the phase 3 trial. And hopefully that helps to get insurance companies to be able to reimburse it at a better rate. We do have samples that we give to patients as well. So the Strat Pharma was very kind in giving us a very small 50-gram tube sample to get patients to start using it and applying it. And that was helpful because it does take a few days for the prescription to take effect and the patients to actually get the cream. And then on top of this, if you look at the data from Strat Pharma and their protocols, there is a slight chance that patients could have an allergic reaction to it. And we did experience that, but very rarely. In my own patients, from all this time, I could remember about 2 or 3 patients who developed what may have been radiation dermatitis, or it may have been an allergic skin reaction. But we stopped the StrataXRT for them, and then patients got better. So I think the risk of an allergic reaction is quite rare, and we talked to the company about that too. But the one of the key limitations that, many clinics have in the US have mentioned is the insurance barrier.
And was there any point in time where you felt that may have led to changes in the overall treatment time?
Yeah, that's something that one of the reviewers had asked us in this analysis. Um, we looked at that. The overall treatment time was not significantly different. There's many factors that go into that besides radiation dermatitis. Whether the patients can tolerate chemo, whether they get admitted, whether they have nausea, pain, dysphagia, they need a G tube. And so this particular factor did not, in our data analysis, did not cause a disruption. It's also partly on how we actually intervene when patients do have grade 2 radiation dermatitis. Once we see that the skin is peeling and there's moist desquamation, we actually stop the StrataXRT and we change them to Silvadene and Mepilex paddings. And as a result, we very rarely in our data ever see grade 3 radiation dermatitis in less than 5% of patients. And so for those reasons, we don't actually witness you know, a, a decreased time that the patients are on treatment with StrataXRT because we have this quite rigorous protocol. We also looked at the time to did StrataXRT decrease the time to or the incidence of getting Mepilex or Silvadene. And that was a bit tricky as well because we started that practice right around the time we started StrataXRT. So historically, patients weren't getting Silvadene and Mepilex as quickly. But then 2020 came when we started using StrataXRT. When moist desquamation happened, we rapidly converted them. So it's just the real world nature of our practice didn't lend itself to those outcomes, but we did look at them and they were asked about it when we were publishing the paper.
Cool. And before we wrap up, if there's any key takeaways from the study that you'd like radiation oncologists listening to this podcast to know moving forward, what would those be?
Yeah, I would say that number one, if you have a practice, whether it's in head and neck radiation or in breast radiation, also in gastrointestinal radiation oncology, where you are dealing with skin doses, you ought to consider doing StrataXRT and talking to the company. Strat Pharma, they do come to ASTRO and many of the expos, and you could talk to them, get some samples and see if it works. We hope that this paper gives some evidence such that the insurance has more support for approving it for patients, and we can consider it. There's a clear benefit. If you just do it in 7 patients, you could potentially spare or significantly delay a grade 2 radiation dermatitis. So I'd say consider it. There are also data in breast cancer, and I think there's some ongoing trials in gastrointestinal and particularly in anal cancers. And I think from our experience, patients also quite liked it, and they didn't complain that the cream was too greasy. It actually puts on quite well, and I think it was pleasant for patients, and we saw some real benefit from it from our data.
Thanks for sharing. Well, so Dr. Savjani, this was truly a pleasure to have you with us tonight. And I think that as a second-year radiation oncology resident who has an interest in head and neck, cancer treatment, that really thinking about ways to mitigate toxicity and discomfort to patients while the treatment is going on, it could be very impactful on them finishing treatment, being comfortable, and just making the experience pleasant overall. So for listeners interested in learning more, you can read the full article and other recently published CURiE research at acro.org/CURiE. Do you have any other ending remarks before we close?
No, thanks for having me, Dr. Fahmy. Yeah, the paper was published in the journal Curious. Please feel free to check it out. It should be available as open access. And yeah, Dr. Fahmy, I'm happy to hear that you're interested in head and neck radiation oncology. If we can help, with that, with your career trajectory in any way, we're happy to help you as well.
Yeah, I appreciate that. Well, thank you to our listeners for listening to CURiE Conversations, and we'll see you next time.